Thank you, OSWB, for this kind of opportunity. I'll be speaking, like Sir mentioned, management of advanced diabetic retinopathy in cataractous eyes. A lot of this has been actually taken up by ma'am, Shubhadra ma'am, and we will just, kind of follow up with the discussion. So diabetics with retinopathy are more prone to develop cataracts, and it's not always that you have, soft cataracts. You can have hard cataracts too. Now, poor glycemic control, younger age of the patient's onset of diabetes, longer duration of diabetes, associated diabetic retinopathy, diabetic macular edema are the most important risk factors for occurrence of cataracts in diabetic patients. Now, we have to actually decide whether to go ahead with the cataract surgery first, how hard is the cataract, and also figure out how is the retinopathy status. Now, most of it can be managed by comprehensive ophthalmologists, and you don't have to refer all cases to guys like us doing VR surgery. So the IGO has come up recently with a publication where there's a nice flow chart. The bottom line is management of diabetic retinopathy with coexistent cataract depends on the retinopathy stage and the cataract grade. So let's kind of visualize a certain few situations so that you can take back home something. So many a times you will have post VR cataracts coming to you. Now these are hard cataracts. Very important to do a proper dilated slit lamp examination. Just don't go home thinking, okay, grade 4 kar denge, because often you can have a shaft injury to the posterior capsule, and you have a drop nucleus in during the surgery. Now let's take up this case. Female lady, 60-year-old, post VR, 636 partial vision with some macular edema, which has come back after a previous vitreoretinal surgery. That was a vitreous hemorrhage removal some time back. So you can do this surgery carefully, of course, and all of you are good cataract surgeons, and just inject something. It could be your injection of choice. It could be a biosimilar, it could be a dex implant, IVTA, or any anti-VEGF for that matter. Let's move on. So like ma'am mentioned, slight ERMs do not need removal. So in this patient, this is a post PRP scenario. You have some fresh vitreous hemorrhage here, some it's a hazy sort of a picture because of some cataract that's there. So here what you can do is you can do the cataract surgery. Again, take care to inspect the cataract very properly, and give an anti-VEGF, or maybe a dexamethasone if the patient can afford, because anti-VEGFs can actually aggravate the ERMs, whereas dexamethasone will not cause any damage to the ERM. But if you are giving a dexamethasone, do a proper pan-retinal photocoagulation. Why dexamethasone? Because once you do the cataract surgery, the edema will be aggravated. Otherwise, if the ERM is not there, you can jolly well, for this mild kind of edema, you can give a biosimilar and follow it up with laser after 2 weeks. Now let's move on. Like ma'am mentioned, when you have a VMT of a similar kind of a situation, then actually you can go ahead with a combined surgery. If you don't have a VR surgery at your place, you can do the cataract surgery, explaining to the patient that you are going to need this subsequently, the surgery subsequently, and you can send the patient subsequently also. But if you have the opportunity, you can do a combined phaco-vitrectomy with endo laser and IVTA maybe, and this is the result of this patient. From 624, patient improves to 69. I've done PRP here also, along with the cataract surgery and the vitrectomy for removal of the VMT. And sometimes you have very minimal cataract. So be wary of doing cataract surgery in this kind of situation with this kind of a picture, because you actually, when you see a DME, you have to do a OCT. Very, very important. If you don't have a OCT, you can end up with a situation like this: traction, lot of neurosensory detachment fluid here, and so it's very important to do a vitrectomy here rather than going ahead and doing the cataract surgery. So you have to remove the the vitreous traction, and of course you need to put in dexamethasone implant or IVTA at the end of the surgery, and of course don't forget to do laser. So this is something, of course, in the VR realm. Now sometimes it's a double whammy. Like ma'am mentioned, a lot of these patients have NVI. The NVI has not come out very nicely here. So NVI with a dense cataract, with you cannot see the fundus, and you have an ultrasound picture that says something like this: sort of TRD with multiple attachments, thick retina. So these are bad cases. So caution is advocated here, and you have to do a phaco with of course, implantation with pars plana vitrectomy, IOL implantation with pars plana vitrectomy, and of course, don't forget to do a, give maybe anti-VEGF. So, these are situations where this can be really testing, because this is a patient that I have done very recently, and, these patients are kind of patients who have lots of morbidity. So you can see this shaking, which is actually, shaking by the patient's, breathing. So you have to be very careful while doing cataract surgery in these patients, and any maneuver. I'm doing a bimanual vitrectomy here, and these kind of, small cauterization can in fact puncture the retina because the patient is moving. So you have to be adapting, doing this carefully. But having said that, these patients actually, do fairly well, because, you can expect 636, 624 vision in these kind of patients if taken care of, properly. So it's basically horses for courses, and, depending on the situation, you can actually take your pick and do the surgery. Most of it can be done by a comprehensive ophthalmologist. Thank you for your kind attention.
Oh, thank you. So, Dr. Aniruddha Maiti, your take on this paper?
Debdulal, in the first case, will you not prefer to give an Ozurdex along with the cataract, because it will stay for a longer time and will address the post-cataract inflammation as well, instead of giving a biosimilar?
Absolutely, absolutely. But cost is a factor. So depending on that, my first choice would be a dexamethasone implant, or maybe IVT, or maybe biosimilar. But today we have long-acting anti-VEGFs also.
When there is a VMT, the VMT what you showed, I think it's always better to combine a cataract along with the VMT surgery, or rather do the cataract and wait for the complication to happen and then do the retina surgery.
He said it's better to do together.
It's better to do together.
Yeah,
Yeah.
if you have
and on the other hand, actually, the last case, when there is an advanced PDR, it is always better to deal the retina part, make it stable, along with the oil removal, if oil is given, do the cataract, I think, because it will prevent the neovascular glaucoma in those cases.
Absolutely.
Yeah, I think one thing very important to understand what you showed, patients can go into pulmonary edema and cardiac arrest very easily. They have multiple systemic problems. Putting an IV cannula before you shift the patient, that's very important. Having them been seen by a physician to know what is their comorbidity is very critical. Your team should have undergone, basic life support every day in our theater, because of course we are dealing with very complicated cases in a tertiary center, but we have handled pulmonary edema. You can lose the patient very suddenly. So the moment the patient, so we put a BP cuff, we put a pulse oximeter in all these patients. The moment the BP rises, patient is breathless, we stop the surgery. And that is one of the reasons why some of these patients, we do a two-step surgery. Because when you do two surgeries together, the duration of surgery is very long. And for patient to lie down on the table for that time, so see the health of the patient, see how he is, don't do surgery. So I have had patients, when I'm looking at them, I think they're going to die in 1 month. They are having all puffy faces, they have proteinuria and all. Madam, cataract surgery kar do, next month karenge. Next month I see their name in the newspaper. Okay, so they can die. Their systemic condition you have to evaluate when you have all these comorbidities. That is very important, and be ready for any eventuality, especially if you are a surgeon who was in the isolated clinic.
Yeah, that's a very good point. Another point, madam said ERM छोटा सा थोड़ा सा होगा. It's not a big deal for a cataract surgeon. And what about some intraretinal cyst? थोड़ा बहुत हो जाता है उसमें.
It's okay.
It's okay.
See, everything, I think it's very good to do OCT in all your cataract patients. And, if you find some PD or some drusen or some ERM, or even sometimes you have a lamellar macular hole, to explain to them that there's something in the retina which may, hamper your near vision. But many of the patients, they do fine after surgery.
Okay.
But inform them that there's something which doesn't need handling now. The cataract surgery will be done. If your vision is good post-surgery, we only need follow-up.
Or later on.
Otherwise, it can be.
So anything from the audience? Yes?
Just one query, and just to know what others do also. So, as far as the blood sugar level goes, when do you accept it? It's something that they have done 7 days before, 2 days before, 5 days before, or the very morning of surgery. The second thing is that the AIOS guideline is 200 post-prandial and 160 fasting. Frankly speaking, I do, because we are in an institution, I go up to 299. It's not 300. Telling the patient and their attendants the comorbidities, because we have seen cases where the sugar does not come down despite all therapies given by the endocrinologist. So what to do? Let the cataract get harder and harder and let the patient have other things getting into the eye, or we do it and then maybe control the blood sugar even better just after the surgery.
Everything depends on informed written consent. So what we do is follow the AIOS guidelines, but in a situation where we can't, say patient comes with 300 sugar and he has endophthalmitis, we can't wait. So if you are doing cataract surgery at 299 pressure, you've already tried 2-3 months to get the sugar, take an informed consent, explain that we are doing it with 300 sugar, there is some risk of cardiac problem, there is some risk of infection, but you have to be under proper care and there is a good chance everything will be over, but there is some risk. And take that high risk consent,
Is it necessary to get the sugar done that morning also?
We are doing it like what we have said within a 1 week of
If
surgery
I
is
can
fine.
add, so coming back to your question, 2-3 things. One is, no matter when the sugar has been done, it's always important to do the sugar on the day of the surgery. Number one. Number two, all my patients I do only sort of post VR phacos and phacos which are not done by the usual. I'm leaving aside Oyanda, Orubda and big guns like Siddhartha, Rotisda here, Orubda here. But for routine cataract surgery also that comes to my OT, all patients are on, have a cuff, have a pulse oximeter, have a infusion cannula. Because like ma'am mentioned, last month I've had a cardiac arrest on table. So that was managed because these were there. Otherwise, we wouldn't have known that the line is flat. So it's very important to do your and be. I'm a conservative surgeon. Something goes wrong and the patient has 299 sugar. The court is not going to leave you. We had a OSW
So-
session some days back, but it's very controversial.